Good day, everyone. My name is Chris Buller, and I'm the medical director at Teleflex. I'm an interventional cardiologist. Today's session, however, is featuring two eminent vascular surgeons. And so I'm a little bit outside my comfort zone today, but I'm looking forward, like you, to learning lots from our guests. The title really is a roundtable. It's a roundtable about large bore access and closure in the setting of EVAR, and with a special emphasis on MANTA, but not just about MANTA, about the larger subject of large bore access and closure. And to kick things off, I thought I'd just get our guests, who I'll introduce in a moment, to tell us about their practices. We have with us today Mr. Chaudhuri from Bedford Hospital in the United Kingdom. Mr. Chaudhuri is also the associate editor of the European Journal of Vascular and Endovascular Surgery, very well known on the continent as well as here in North America. And we have Dr. Chance Dewitt as well from the CHRISTUS Hospital in Alexandria, Louisiana. Dr. Dewitt, welcome as well. So let's get started with a conversation about your practices in EVAR and your management of large bore access and closure, perhaps as it existed towards the beginning of your practices when the landscape was somewhat different than it is now. Why don't we start with you, Dr. Dewitt? What did your practice look like when you started?
Early on in my training 17 years ago, we mainly did bilateral cut downs to place our EVARs in. And at the time, I was training at Texas Heart Institute, and they were just beginning to do some percutaneous access. But the failure rate was fairly high. And of course, they had a plethora of vascular and cardiac surgeons around that usually would be able to manage the problems if the access got away from them. And you would like to hear this, Dr. Buller. One of the cardiologists there was so good at it, he would almost start the cut down before the surgeons would come down, and did a quite admirable job. But over time, I entered into practice and continued with the cut down technique. And then over time, as the different devices improved, we started to go toward percutaneous access. And then currently for most of my large bore access, if I have access to the device, we begin to use MANTA as well.
Great. I love the anecdote about the interventional cardiologist starting the cut down. You know that we're all frustrated surgeons. In my
well, I have to admit, he would do a quite admirable job, and we enjoyed working with him. Actually, that's who trained me to do EVARs.
Isn't that interesting? That's great. Yes. Well, my surgical colleagues in Tabby know that they have to hide the scalpels on me, or else I'm likely to pick one up and be a danger. Mr. Chaudhuri, welcome as well. Tell us about the nature and landscape of your practice as you entered practice in EVAR.
So thank you. I think the evolution of my approach to access is a bit like Dr. Dewitt's, and it was a bit pseudo-political in those days, because you would say, well, why would you spend, 90 pounds or 100 pounds on a closure device when it costs you maybe 5 pounds for a single Prolene stitch? So it was arguments like that which would push the access and closure bits towards open access. And also something that's not often said, it kept, in those days, the surgeons slightly relevant, because it was mostly the IR specialists who were doing EVARs, till the sort of newer advent of endovascular surgeons who were able to do the procedures independently. So I think we certainly noticed that evolution, and that evolution has come with the skill set and the mindset of the newer generation of surgeons. So I think for the last, 9-10 years, my practice has become entirely percutaneous for all large bore practice, punctures, whether we've talked about this, retrograde or antegrade femoral, And I think while we've all used, suture-mediated closure devices, I think MANTA has completely changed my approach in another direction now.
Right. Just before we get to specific techniques, so at least in the TAVI realm, the big advantage of a percutaneous closure was really ambulation and the potential for early discharge. Is that an advantage that is gained in your world of EVAR as well by avoiding a surgical incision?
There's two things. There's an interesting paper coming out in the EJVES, which actually looks at, probably a smaller group than we would have liked, which actually seems to suggest no huge advantage in going perc, strangely enough. So that's the other side of the coin. But having said that, with my perc approach, most of my patients are home in 24 hours. And then you avoid the issue of, as Dr. Dewitt will know, the issue of post-operative, seromas and all sorts of things.
Dr. Dewitt, is it rapid discharge that drives percutaneous closure in your practice?
Yes, I think it's two, because most of the EVARs, you need large bore access on both sides. So you go from, a percutaneous approach on both sides to actually an open approach on both sides. And I find with the percutaneous approach, 90% of the patients go home the next day, the next morning. Our biggest reason why they don't go home is urinary retention. And also, I think just the benefit to the patient of not having, especially our obese patients, which they tend to occur more frequently, the infection rate and seroma rate is negligible with the percutaneous option. Now, obviously, there's always a risk of infection with both and even the percutaneous, but the surgical complications of an open groin incision are now negligible with a percutaneous approach that you just don't see that much anymore.
Right. And on a worldwide basis, Mr. Chaudhuri, where do you think we stand with regard to the penetration of percutaneous access generically for EVAR? Is it standard of care everywhere, or is it still in transit?
I think it's sort of heading more towards a 70-30 thing, and the 30 of the people are still hanging on to open access. And that's probably a combination of lack of awareness of closure device usage sometimes, and sometimes maybe a lack of willingness to engage with percutaneous techniques, and people just hanging on to the things they're comfortable with, as we all do.
Yeah.
So I think there is that, but the advantages that Dr. Dewitt mentions are clearly a given to us as well. And the other thing I think that gets lost in the mix is I have anesthetists who don't like giving general anesthetics for these patients. So I will do the vast majority under local anesthetic with a bit of sedation.
Yeah. And in the US, Dr. Dewitt, where are we? Is it 70-30 percutaneous, or are we farther than that or not as far as that?
I would say it's probably 50-50 or 60-40. And I think it's highly dependent upon the institution in which you practice. Obviously, if you have mainly someone that does endovascular work and is not a surgeon, and they recruit a surgeon to help, a lot of times they're going to probably err more on the side of cut down. And I think the big thing is if you do large bore access and it gets away from you, it's quite distressing if you're not able to do something immediately, because this is, it's not a 5 French or 6 French hole that you can pretty much manage with pressure. Yeah. These things can really, really bleed rapidly. So I think, depending on the backup someone has or the ready availability of someone, also plays a lot into how they're going to manage the groin access.
Yeah, great points. We might come back to this at the end and talk a little bit about how we can support practice change in the places that have not yet embraced percutaneous access. But I think we'll move on right now to some other more specific subjects. And what I'd like to get at is really starting with Mr. Chaudhuri. I want to hear about the transition period when you were first adopting MANTA. What were the key observations that you made, both in the broader procedural medical sense, but also technically? Were there other things that changed when you adopted MANTA? Did your technique for access, for instance, change? What was the field around the groin looking like, and how was it modified as you adopted MANTA?
I think my access principle has always been the same, i.e., ultrasound guided access for all. I think that goes without saying. But I think where MANTA has come into its own is first of all, it's a post-close device, so to speak. So there is very little pre-close preparation, as we know. And the other thing, and that was never looked at the sort of the IDE trials and so on, the pivotal trials I meant, was the fact of how versatile it could be depending on what sort of groin you were approaching as a primary or a redo field, so to speak. So I've taken MANTA on for all comers, whether you have a primary groin, redo groin, antegrade, retrograde, the whole lot. And I think that's what has actually expanded the horizons for me. A, the lack of preparation, and B, you can just get on and deploy it.
Right. How about you, Dr. Dewitt? Take us back to your first few months of using MANTA. How did it fit? How did it change your approach to access? How did it modify the care of your patient early on?
Right. Early on, I think that when you go to use MANTA, if you're familiar with other devices that are similar to it, it makes a little easier transition to using this one. Is maybe going from a suture-based closure straight to MANTA. So I would say that will allow you to feel a little more comfortable using the foot plate and plug. When I first started, just as I did with any other closure device, as I would echo Dr. Chaudhuri, I mean, the cannulation, the common femoral, the evaluation of the common femoral access or access vessel you're going to approach, as well as the cannulation of the vessel, pretty much, in my opinion, decides how successful the outcome is. And the device, I think, is, as far as MANTA goes, the consistency in which you can deploy the device is the beauty of it. Because once you do a few and get comfortable with it, with some observation from possibly the rep and different things, training, I think the time from just beginning to full usage is very short. I think the learning curve is not very big.
That's good to know. And we've heard that from a wide range of operators, that the learning curve is shorter than some expect it to be. Not to say that there aren't some subtleties that emerge after a large number of cases, but you're fully competent in fairly short order. I'm thinking though that the skills of percutaneous access may not be fully developed in a program that is not using percutaneous closure. It's very easy to stick the common femoral artery when you're looking at it. Having done that a few times myself, it's not as straightforward or consistent to get excellent top dead center common femoral access well free of the bifurcation when you're percutaneous. Mr. Chaudhuri, do you want to talk about the skill sets that are key to that kind of consistent access for operators who might currently be using an open approach? What do they need to develop in terms of skills?
I think it's quite easy, actually. I mean, most of us, I think the key is to learn how to visualize the common femoral artery in both the axial views and the longitudinal views. Sorry?
This is with ultrasound you're referring to?
With ultrasound, absolutely. Absolutely. Yeah. And the mantra I tell my trainees is it might be access, but what you do at the very beginning of the procedure is what you face at the end of the procedure.
Yeah.
And that aspect must not be neglected. Otherwise, you end up in the scenarios that Dr. Dewitt was talking about, where you have, a failure of hemostasis and you got to get in, all guns blazing, get the operative sets out, start opening the groin, and something that was calm and controlled suddenly becomes messy and uncontrolled. So, and this again sort of colored my my preference towards switching to MANTA, because we know that, yes, patients who need large bore access for EVARs or TEVARs usually have dilating disease.
Mr. Chaudhuri, in your indication that you've used MANTA now on an all-comers basis, I am interested in knowing whether there's any particular patient group that you felt suture-mediated closure was problematic for.
So the answer to that is yes, and I can think of two specific groups. The first ones are the group of patients who have a lot of wall calcification in the femoral artery, and you would anticipate or actually really experience that the suture-mediated closure devices don't actually engage properly to create a through-and-through suture. So you will get a high rate of failed deployments, or, as Dr. Dewitt has suggested, you will need to resort to cut-downs. The other group is the patients with redo groins, and this could be redo from either previous percutaneous procedures or open cut-down. But the commonality between the two would be a high element of periarterial fibrosis. Again, this would likely preclude successful deployments of suture-mediated devices. But in my experience, as we've already done these cases, that has absolutely no bearing on the mechanics of a plug-based device, which is completely independent of those other factors. So yes, that's where I found MANTA to work.
All right. Yes. Obviously, the access, the beginning of the access is critical. I usually do not use ultrasound, although it is very helpful. But what I do use is the micropuncture technique, and then the inner sheath on the 5 French sheath. I place it in and take my angio, and I find that you're dealing with such small puncture sites that a lot of times it allays the anxiety of coming back, taking it out, hold pressure for just a minute or two, and then reaccessing where the vessel is appropriate. And that's tends to be the way I access it, as well as after reviewing the CT angiogram and getting the layout of where the profundi is in regard to the femoral head and different things like that.
Yeah, that's incredibly important. So you don't, many TEVAR programs go around the horn, so to speak. Of course, in TEVAR, you've only got one large bore access. Would put a catheter around the horn at the aortic bifurcation, take a picture, an angiographic picture. That's something that I did early on, but I abandoned that with such high quality CT. I felt that has become a redundant maneuver, and it's just extra contrast and extra time. You agree with that? That's not part of your routine.
I think that was our exact routine when we first started. Of course, I had been using the device with my EVARs, so that when we got to percutaneous aortic valves, I was not, pushing to confirm that. But a lot of my cardiology colleagues were very, very rigid about it until they gained comfort with the device, and after a few, they abandoned that as well for those exact reasons.
Right. Now, one of the things I've seen when I visited labs, which concerns me, is the use of micropuncture or the use of ultrasound, followed by a puncture that's not quite right, and then kind of, well, we'll live with it, rather than taking advantage of the fact that you can see that it's not quite right, backing out, starting over. What would you say to operators who having made every legitimate attempt, every honest attempt to get a good access, don't get a good access? Do you carry on or do you back out? It's a sort of an obvious rhetorical question, but it's amazing in my experience how often people will continue after documenting poor access.
Well, at the end of the case, they'll wish they would have backed out.
Okay.
And a lot of times you can get away with a lot of things, but I think it's a numbers game. So going from having less than a 2 to 3% issue with it, you're going to increase that to about 20%. Having an issue at the end of the case, whether it's an occluded SFA or profunda or some other reason. So, yeah, I would re-echo that. That's why I use the micropuncture technique. So my anxiety or the reason for not accessing the vessel is much lower. And I just don't think about it that much, because I would agree with the micropuncture techniques, the versus that 18 gauge needle, which I would think, yes, that would be a difficult, taking it out, because once you develop that hematoma over the artery, it just makes it harder and harder. And then you're obliged to use an ultrasound guided measure, which is much more difficult now that you have a hematoma over the vessel.
Yeah.
So I think that sort of echoes my point about, what if you don't get it right in the beginning, it comes back to haunt you at the end.
And that's an excellent teaching point.
Yeah, you two are lockstep on that, and I would agree wholeheartedly in my TEVAR experience. Now, one of the key differences of TEVAR and EVAR, and I really have to acknowledge my lack of comfort with this matter, is the bilateral large bore access closure. That gets my attention. Tell me about as you adopted MANTA, were you bilateral off the start, Mr. Chaudhuri, or did you learn unilateral, and then how did you approach that?
No, I mean, I didn't even make that distinction, to be perfectly honest. We've always accessed 2 groins. We're still always accessing 2 groins. It was simply 1 groin times 2. And that's all it was. The only subtle difference being that the larger device will tend to go in through the right groins, which is usually an 18 French or above, or if you're dropping down to an ultra low profile device, it'll be a 14 French. So you can still use a 14 French MANTA for that. And the contra groin will be typically something like anything from a 12 French upwards, for which we can use a 14 French MANTA anyway. So that was it, really. It was just a matter of defaulting usually to the 18 on the IPSI side and the 14 on the contra side. And that's all it was.
Right. No concerns about the fact that some may feel that they've closed the door on re-access with 2 fresh collagen-based closures. No concern on that front?
This is where I take it slightly out, and I'll give you a little personal experience on that. So, in fact, we did have closure device failure in one of my patients who was quite unfit. And so the next day we realized he was developing a on the way to developing a proper groin hematoma and a pseudoaneurysm, and we couldn't let that lie. So, this would bring in all those issues. You got a hematoma, so it's difficult to puncture. You got an unfit patient who you don't want to give a repeat GA in. Where do you access from? So this sort of links back to your question. An access vessel is an access vessel. So I went retrograde popliteal, in fact. So you can choose any vessel as long as it's big enough. I don't think it matters. So even if the MANTA is occupying that space, there is always somewhere else to access.
Yeah. Well, that really does speak to your comfort as a vascular surgeon with access points that I would not be comfortable with, never having done a popliteal access. I mean, I'm sure I could bumble my way through it, but it would show. Dr. Dewitt?
Yes, I think you would be forced, unless you had a long area of common femoral, you would probably have to go to alternate access. But the MANTA is also very nice in that it lets you know exactly where it's deployed. Yeah. And if you use the device, I would highly recommend looking at the foot plate that is in the vessel. It's quite substantial, but it gives you an idea of maybe where you would need to access an artery that would be close by. But yeah. I would agree with Dr. Chaudhuri. You'd probably have to go to another vessel if you needed to re-intervene.
Because the steel lock also shows us that, isn't it? Because if you just do a fluoro, you'll see where the steel lock is, and that gives an indirect guide as well.
Yeah. So, Dr. Dewitt, we heard from Mr. Chaudhuri that he is essentially using MANTA in all comers. I think from our past conversations, I understand you are somewhat more selective. I wonder if you could tell us about the patients you prefer not to use MANTA in and prefer another form of access or closure, perhaps even open.
Yeah. Usually whenever I have a patient that I consider to be a candidate for percutaneous access, the CT angiogram, in my opinion, is critical for preoperative planning to decide if they're a candidate. And usually what I look at is vessel size as well as the consistency of the vessel, mainly the amount of calcification or bulky calcification that I see that may extend into the arterial wall or into the arterial lumen. And those patients, most of the time, I will stay away from quite honestly, percutaneous access in general and opt for a open access route.
And does it make a difference to you whether that plaque is oriented predominantly anteriorly or posteriorly? Is that a consideration as you look at those images?
Usually, if I have a vessel that's fairly sizable, if the calcification is limited to the 50% posterior wall, then I will tend to go ahead and use a percutaneous closure. If it begins to extend up along the lateral walls or involve the anterior wall, you're correct. I would tend to stay away from a percutaneous closure.
Dr. Dewitt, as I recall from our previous conversations, your practice does include TEVAR. Have you had experience with MANTA in TEVAR?
Yes. Early on, the devices were considerably larger than they are now, and most of the guys that supported TEVARs were very critical of any percutaneous closures or techniques. But I will admit, since we began to use MANTA, I've gone to that's my preferred option to use. And I think it's been very successful, even for the larger bores up to 18 French that you occasionally may need to use. And it definitely makes it a lot easier doing so than another cut down, because most of my patients are trauma patients that already have so many other problems going on at the time.
And Mr. Chaudhuri, is TEVAR part of your repertoire?
Oh, yes, indeed it is. And I think Dr. Dewitt made a good point that the TEVAR devices, even though the profiles are coming down, they will still tend to be slightly larger profile devices. So I think MANTA lends itself perfectly to these larger bore devices. But having said that, I actually undertook to redo TEVARs recently. So we're talking about both large bore access and also redo groins, which would probably preclude the use of suture-mediated devices. So MANTA just fits in perfectly into that.
Let's talk a little bit now about the adoption on a hospital based level. So the modern hospital in which you both work has a process associated with the adoption of new technologies. And the committees are often highly sensitive to devices that increase the immediate procedural costs and relatively less sensitive to downstream costs. At least that's been my experience, having worked in a couple of hospitals. Tell us about your approach to the adoption of this administratively at your institution. So start with Mr. Chaudhuri.
Actually, thankfully, this is a discussion we always have about new technology and new costs. In fact, I did a cost analysis between MANTA and other devices, which we published in the Journal of Endovascular Therapy. So it's there to have if people want to have a read as a little letter containing this cost analysis. But thankfully, because we're a regional vascular hub, as I mentioned the last time, because of the centralization pattern in the UK, we were able to get it through with very little protest from our procurement costing groups. So it's, well, sort of went through, thankfully, with very little friction.
How about you, Dr. Dewitt?
I think it's highly subjective to the individual hospital that you practice at. Some are going to look absolutely at the direct cost versus any competitor, and they will be unyielding. And others will want to see benefit downstream, as well as if the device is close in cost, it's of no concern to them, and a lot of time, a lot of the care is just doctor driven, and it will not be a very difficult selection at all.
Let me ask now about teaching this, and have either of you had experience going out to centers? Excuse me, going out to centers that have not yet adopted this and helped with the teaching of this. Tell me about that experience if you've had it.
Who do you want to start, Dr. Buller?
Either one of you.
Dr. Dewitt, if you want to go.
Yeah, I've had some teaching experience with colleagues that I work with, and it's been fairly easy transition for most of them. I think the biggest thing that some have to be very careful about is maintaining constant pullback pressure.
Yes.
At 45 or more degrees in relationship to the skin. And then while pulling back, not letting the whole device move forward when you go and seat the plug. You really need to keep that arm locked as you're pulling the foot plate up to the artery and then pushing down. And I would say once on your first try, if it's seated, it looks good, it's not bleeding, don't make it better. Just leave it as it is, and it's successful, and you can trust it. But, if there's some oozing afterwards, you may want to try to add a little extra pressure, but it's critical to maintain that foot plate against the arterial wall with the appropriate amount of pressure indicated in the window on the device. That would be the main thing that I go over with the guys when we do it.
That is a very common technical glitch or technical error that we see teaching this device. Two aspects of that. One is the lack of recognition that there is a time dependency for any collagen-based closure. I guess every closure technique has a biological component, even open suture-based closure. You would, I'm sure, tell me if I was a surgical resident that, a tiny bit of oozing through the suture holes will settle down. But it's much more obviously a biological process when you're using a collagen and foot plate based sandwich. This really needs to set up like a high speed epoxy glue to create full closure. And I love what you said a moment ago about accepting a little bit of oozing in the first few minutes as that sets up. The other mistake that we've seen fairly systematically is that moment. As you're withdrawing the device, there can be a spurt of blood. Totally expected, totally understandable, not a malfunction, not a failed closure in the making. And we see people rush through that or rush and put a hand on the groin at that point, which is probably the worst thing you can do in terms of letting the device get properly in apposition. Any comments on that in teaching? That seems to be particularly a problem in thinner patients where that little spurt will come to the surface more easily than in a deeper access. Mr. Chaudhuri, thoughts about that?
Yes, actually, we found a workaround for that.
Tell us.
So I think that first comment is very important. That left hand needs to be locked in space wherever. You put your elbow on the table, you lock the bottom of your fist against the patient's groin. But, I've been teaching a few colleagues, and the one failure we had was where the left hand was not entirely in control. So we could all say, yes, you've got the device at 45 degrees and you've come to your X number of centimeters plus one to line up the markers at the level of the skin. But if your hand moves, that's all gone. It's all wasted. And that was the failed deployment. So I think maintaining that left hand stillness becomes absolutely critical to a successful deployment. Because it could either pull upwards if you're not careful, or it could push inwards as you're locking the main device in.
Yeah,
and that's
Is your point of reference there the table, or is it the patient themselves? In small bore closure, I make the same point with angioseal. How incredibly important it is that your hand be resting firmly against the anterior iliac crest there, so that you can absolutely not move in relation to the patient.
So it is pretty much that. So it is that resting surface of the the wrist and the fist, so on the patient, and upwards towards the ASIS, as you've mentioned. The bottom line is to maintain that rigid fixation.
Yeah.
So that was the one thing. The other thing you mentioned about is that spurt. So I recognized that quite early on. So before I'm pulling the device out in order to tamp the collagen plug in, I found a very easy solution. So I tell my residents to put a finger one up, one down below the puncture. And that controls everything very well. So once I've deployed the plug, that's when I tell them to take their fingers out. And then I can see if I've got hemostasis or not. And actually, you don't get that spurt anymore.
Wonderful. We'd love to have you demonstrate that in a video. We'll get you on YouTube with that. That's a great teaching point.
Okay, I'll probably do a video. Then we could do that.
Yeah.
And the only thing I would have to also add that I found for some, we see a lot of obesity here, and to make sure when you gauge your depth, it's at the same level, meaning that did you do it when you pulled out and the skin is tented, or did you push it down moderately so that it's back flat where they're anatomically the skin is at? And so you want to be, in my opinion, very careful on especially obese patients, kind of where you're measuring in regards to how you're setting it up and how the skin responds to pulling back the depth measurement.
Absolutely. I mean, it's the same, that 5 centimeters you had on your way in should be the same 5 centimeters on your way out.
Yeah. This actually raises an interesting point because, of course, in many teaching programs, certainly in my specialty, in many teaching programs, the person who does the vascular access may be a different individual than the person that does the closure. And you can probably get away with that in suture-mediated closure. What do you think about that with MANTA? Does this need to be the same person?
I think it needs to be a person you trust.
Yeah. Okay, fair enough. Because, often there is a need to remember exactly how you did it at the beginning, is there not? Yeah.
Absolutely.
Yeah. Good. Okay. Well, we're drawing near the end here. I want to just come back to the subject of the fairly widespread, perhaps even more in the U.S., as we heard earlier, widespread continued use of cut down for access. How do we approach that? How do you approach this to your colleagues? This is obviously not something for a corporation to address. This is something amongst professionals and for professional societies. But you obviously are both believers that percutaneous access through whatever technology people are good at is superior to open access and should be the standard of care. Am I putting words in your mouth? I think that's what I heard. So how does your specialty move to achieving that? What are the steps that you would like to see to changing that? Is it just education? Are there guidelines that need to change? Tell us what your thoughts are. Mr. Chaudhuri.
The first thing I think is one-to-one dialogue. Usually, you often meet people in conferences and they will say, "Oh, right, really? I just don't go there." And that's the first stumbling block to be crossed. And there won't be any amount of conferences or educational programs that will overcome that, I think, bar a one-to-one discussion And that would then lead on to maybe a visitation, an actual, proctorship through a percutaneous access program, whatever it might be, a demonstration of a case. And it's just overcoming those personal hurdles, despite the talk of, being objective and scientific, we all have little personal biases. And I think that has to be addressed on a personal level. And then the rest of it comes.
Yeah. Dr. Dewitt?
I would probably tell you, I would say, I don't know if you could say, or I would agree that it would be the standard of care, because I think once you label the standard of care, that means we do it on every groin. And that's not feasible, which would lead maybe to not the outcomes we would desire, thus giving a device a bad name. But I would say it's probably the preferable route for that. As far as adoption, I would say, I think over time, you can't go wrong. Whatever's best for the patient is going to eventually declare itself. But let's say we go a different route. With this device, there's a multitude of things that are really nice about it. And I would say the consistency of deployment, the time saved with this device, with other percutaneous closure devices, this device is superior, as well as I'm a fairly rapid surgeon, but I don't think I could close and open a groin as fast as I can deploy and get my measurements for the MANTA. There's just no way. I mean, this is I would say the whole device, pre-procedure, post-procedural, and you correct me, Mr. Chaudhuri, but I would say at a long point, maybe 5 minutes per groin versus surgical 20 minutes for the easy ones per groin. That's 40 minutes versus 10 minutes. And even our other devices, you have to deploy 2 of them at a time for each groin. So I think from that standpoint, it's superior. And most physicians are very concerned, and even the ORs or endovascular suites, about time utilization. I think that is a big deal, as well as the consistency in which it causes hemostasis is very nice. And quite honestly, it seems to me, I have no study, but I see a lot less large hematomas in the groins as well, just over time. And complaints from the patients.
Great. Well, that's probably a great wrap up, Dr. Dewitt. You've done a nice job there of summarizing some of the issues and advantages of percutaneous access and closure in general, and of the MANTA more specifically. So it's a great place to wrap it up. I want to thank you both, Mr. Chaudhuri from Bedford Hospital in the UK, Dr. Chance Dewitt from CHRISTUS Hospital in Alexandria, Louisiana. It's been wonderful having you both on. I hope it's a conversation we can have again in a year or two. Thank you so much for your time today. Thank you both very much, and we'll see you soon.